Okay, let's unpack this. When you're in the thick of neurology residency, it really hits you just the sheer variety of ways the brain and body can suddenly, well, seem to go offline.
Right. 1 minute someone's fine, the next they're unconscious or they've fallen.
Exactly. And it's those cases, the ones with sudden loss of consciousness or these unexplained falls, that really force you to sharpen your diagnostic skills, don't they?
Absolutely. And what's fascinating, especially from a neurology perspective, is how these dramatic events, losing consciousness or falling, can stem from such a wide range of underlying problems. As a resident, you really start seeing that complex interplay of systems keeping us upright and aware.
Yeah, it's like a puzzle. And that's what we're tackling today. We're doing a deep dive into the medical literature on episodic impairment of consciousness and falls. Think of it as getting the inside track on how neurologists, especially those still training, learn to tell these different conditions apart, building that mental framework.
hmm And for anyone listening who's wondered why someone might suddenly faint or fall, we're aiming to translate some pretty complex medical stuff into hopefully understandable insights, those aha moments.
And connecting it back to residency, mastering these distinctions is just fundamental, isn't it?
Oh, completely. It's not just about textbook definitions. It's about developing that clinical intuition, asking the right questions, spotting subtle clues.
Right, and making treatment decisions that really impact patient safety and well-being.
Exactly.
So our guides today are chapters from medical textbooks focusing specifically on these topics: episodic impairment of consciousness and falls. Our mission: to pull out the key differences between things like syncope, seizures, and all the other reasons someone might suddenly lose their footing or awareness, trying to give a structured, memorable overview.
Sounds good.
So as a neurology resident faced with one of these cases, where does your thinking typically start? What's the initial sorting process?
Well, a logical first step is figuring out if the main issue is a transient loss of consciousness. And two big categories jump out immediately: syncope and seizures.
Okay.
But it's important to remember episodic impairment of consciousness is a really broad term. It covers everything from that temporary drop in brain blood flow, which is syncope, to the sudden electrical storm of a seizure.
Right.
And then, in the back of your mind, you're also considering other things like migraine variants, metabolic issues, maybe increased pressure inside the skull, sleep disorders, even psychiatric conditions. But syncope and seizures are usually front and center initially.
Got it. So let's start with syncope. From a resident's perspective, what's the core definition you're working with?
So syncope, at its heart, is an abrupt, transient, complete loss of consciousness. And the key things are the loss of postural tone. The person goes limp and spontaneous recovery, no intervention needed.
And the underlying mechanism.
It's a temporary failure of cerebral perfusion. Basically, not enough blood flow and therefore not enough oxygen reaching the brain for a short period.
Okay. And what about warning signs? What might someone feel or what might a witness see right before a syncopal episode?
Yeah, the lead up, the prodrome, can vary quite a bit. Common things are feeling lightheaded, maybe weak all over, giddy, vision blurring, sometimes ringing in the ears, tinnitus, or even nausea.
Mm-hmm.
An observer might notice the person getting really pale, maybe sweaty or clammy. And the onset, interestingly, can be gradual, giving some warning, or it can be super rapid, especially if it's related to a heart rhythm issue or in older folks.
And during the faint itself, what are the key features a resident is looking for? Maybe from a witness description?
During the actual syncope, the person's typically motionless. They might have some brief, jerky muscle movements. We call those myoclonic jerks. But and this is important. They're not usually the sustained rhythmic shaking you see in a big seizure.
Okay, so brief jerks possible, but not a full tonic-clonic type movement.
Exactly. And things like urinary incontinence, uncommon in simple syncope. You'd typically find a weak, often slow pulse, shallow breathing, and low blood pressure if you could measure it right then.
And the recovery phase, how does that usually look?
Well, usually once the person's lying down, which often happens automatically because they lose tone, blood flow to the brain improves, normal color comes back, breathing normalizes, pulse and blood pressure pick up. They often feel weak afterwards for a bit.
Okay.
But here's a really key point residents learn to look for. Significant confusion, bad headache, or major drowsiness after the event are uncommon with typical syncope. That groggy, postictal state you see after seizures, usually absent, though any nausea they felt before might linger a bit.
That's a crucial distinction. So thinking about causes as a resident, building that differential diagnosis for this temporary drop in blood flow, What are the big categories?
We often group them under decreased cerebral perfusion. The most common is probably vasovagal syncope, the common faint, right?
Yeah.
Triggered by emotion, pain, standing too long.
Yeah.
Then there are cardiac causes, arrhythmias, blockages preventing blood from leaving the heart effectively,
Yeah.
things that drop cardiac output.
Serious stuff.
Definitely. Other things include low blood volume, hypovolemia,
Mhm.
orthostatic hypotension, that's blood pressure dropping when you stand up, or anything that decreases blood return to the heart. Rare causes could be TIAs in the posterior circulation, or even cerebral vasospasm like you might see with migraines or after a subarachnoid hemorrhage.
You also mentioned situational syncope. What are some classic examples a resident learns to ask about specifically?
Right, those are the ones reliably triggered by certain actions, like a really strong cough, urinating micturition syncope, having a bowel movement, swallowing, straining hard, like with the Valsalva maneuver, or even diving.
Huh. Interesting triggers.
Yeah, the mechanisms vary, but often involve things like reduced venous return or shifts in autonomic tone. And then don't forget metabolic causes, low
Mhm.
oxygen, hypoxia, effects of drugs or medications, anemia, or low blood sugar, hypoglycemia. Though hypoglycemia often causes more of a pre-syncope feeling like you're about to faint rather than a full loss of consciousness. That's something residents pick up on.
Does syncope present differently or have different common causes depending on the patient's age? Do residents learn to approach it differently in kids versus older adults?
Oh, absolutely. In kids and young adults, hyperventilation and vasovagal syncope are super common. You still think about congenital heart disease, but it's less frequent, maybe benign, fast heart rhythms. And in young women, basilar migraine is a more common trigger.
Okay.
But when you see syncope, especially recurrent episodes, in older adults,
Mm.
while it could still be vasovagal, you have a much higher suspicion for underlying organic disease problems with brain circulation or the cardiovascular system. That usually prompts a more thorough workup, something residents become very familiar with orchestrating.
And cardiac syncope specifically is a really high stakes area residents need to be sharp on, right?
Yes,
Yeah.
absolutely critical, because it can signal a potentially life-threatening heart condition. It's syncope caused by the heart rate being too slow or too fast, or the heart just not pumping effectively due to an obstruction like aortic stenosis, or even something acute like an aortic dissection.
So what raises suspicion for a cardiac cause?
As a resident, you learn to have a high index of suspicion if the patient has known heart disease, or if they report palpitations or that fluttering feeling right before they pass out. Another clue is that cardiac syncope often hits very fast, the episodes might be briefer, and importantly, it can happen regardless of posture, sitting, standing, lying down, unlike vasovagal or orthostatic syncope, which are usually linked to being upright.
What about fainting during or right after exercise? What does that suggest to a resident?
Exercise-induced syncope is a major red flag. It strongly points towards a possible cardiac cause, maybe an arrhythmia brought on by exertion or reduced output because of something structural like hypertrophic cardiomyopathy or aortic stenosis.
But it's not always cardiac.
No, and as a resident, you have to keep a broad differential. You'd also consider cerebrovascular disease, maybe issues with the aortic arch, other valve problems, pulmonary hypertension, even severe anemia, hypoxia, or hypoglycemia. And then there's post-exercise syncope fainting after stopping. That could be orthostatic changes, vasovagal response, or maybe underlying autonomic dysfunction.
So, putting it all together, patient presence with syncope during residency. What's the typical investigation pathway? What tools are you reaching for?
Well, the absolute cornerstone is always a really detailed history. Getting all those details we discussed, triggers, posture, onset speed, symptoms, duration, recovery, and witness accounts are gold if you can get them.
Right.
Then a thorough physical exam focusing on vitals, checking orthostatic blood pressure lying and standing, listening carefully to the heart for murmurs or rhythm issues, feeling pulses. An ECG is standard first-line screening.
And beyond the ECG.
Depending on what you find or suspect, you might move to Holter monitoring, maybe an implantable loop recorder for infrequent events, an echocardiogram to look at heart structure and function, or an exercise stress test. Tilt table testing can be useful for unexplained syncope if you suspect a vasovagal component.
What about brain imaging or EEG?
Doppler studies of brain vessels, or MRI, might be done if you suspect cerebrovascular disease, but routine carotid imaging isn't usually recommended without focal neurosymptoms. And an EEG. Generally low yield for simple syncope unless you actually suspect seizures are part of the picture.
Okay, that provides a great framework for how a resident approaches syncope. Let's pivot now to seizures. How do these differ in your mind as you're evaluating these episodes?
Seizures also cause altered consciousness, obviously, but the underlying mechanism is totally different. It's that abnormal, excessive, synchronized electrical firing in the brain. And while history is usually key to telling them apart from syncope, residents definitely learned that distinguishing seizures from psychogenic non-epileptic spells, PNES, or panic attacks, or even malingering, that can be really tricky sometimes.
So what specific clues in the history or during the event would make a resident lean towards seizure rather than syncope?
The biggest one is probably the postictal state. That period of confusion, maybe headache, disorientation, just being slow to get back to normal baseline after the event. Highly characteristic of seizures, much less common after syncope.
Right, that grogginess.
Exactly. Also, seizures usually aren't related to posture. They often last longer than a faint. During a generalized tonic-clonic seizure, cyanosis, that bluish skin color from lack of oxygen, is common, whereas pallor is more typical in syncope. Other potential clues pointing to seizure include an aura beforehand, forceful muscle contractions, biting the tongue, or incontinence during the event.
You mentioned different types. Could you briefly outline the main categories residents need to know in the context of altered consciousness?
Sure. Broadly, we think about generalized seizures involving both brain hemispheres from the start and focal seizures, which start in one specific area but might spread.
And examples?
Generalized types include absent seizures, often starting in childhood, and the classic generalized tonic-clonic seizures. Focal seizures, sometimes called partial seizures, originate from a specific spot and might or might not generalize.
Let's dig into those specific types involving altered consciousness a bit more. These seem critical for a resident to differentiate, starting with absence seizures.
Right. Absent seizures are characterized by very sudden, very brief episodes of decreased awareness, like a pause button was hit. Typically no warning, no postictal confusion.
What does it look like?
You might just see someone stop what they're doing, stare blankly, maybe some subtle fluttering of the eyelids or lip smacking. They're usually super short, like 10-15 seconds. And a classic thing residents learned is that having the patient hyperventilate in the clinic can often trigger one.
Interesting. Okay, then the tonic-clonic seizures, probably what most people picture when they hear seizure, and something residents definitely encounter.
Exactly. These involve losing consciousness, plus that characteristic motor activity. First, tonic stiffening, then clonic jerking. Primary generalized ones usually strike without warning.
What else happens during one?
You often see significant autonomic changes. Blood pressure and heart rate shoot up. Breathing might stop temporarily, pupils dilate, incontinence can happen, cyanosis, sweating. Afterwards, the return to consciousness is slow. The person is typically lethargic, confused, maybe sleepy for hours, and their reflexes might be abnormally brisk right after. Important to note, some people might just have the tonic part or just the clonic part.
Okay, and complex partial seizures. How do they present, and what are the key features for a resident?
Complex partial seizures often start with an aura or warning. This can be really varied, strange smells or tastes, weird feelings in the stomach, motor symptoms, even psychic stuff like hallucinations, illusions, intense fear, déjà vu, or trouble speaking.
And the seizure itself?
It usually lasts a bit longer than absence, maybe a minute or two. Consciousness is impaired, not necessarily completely lost. And you often see more complex automatisms than in absent seizures, like picking at clothes, fumbling, chewing motions, wandering. They can spread and become a generalized tonic-clonic seizure.
How's the recovery?
Recovery is usually gradual, and there's typically a period of postictal confusion afterwards, similar to tonic-clonic, but maybe less profound or prolonged.
So, when a resident suspects a seizure disorder is causing these episodes, what investigations get ordered?
Well, initial blood tests are common. CBC, electrolytes, kidney liver function, glucose, calcium, mostly to rule out metabolic triggers, though usually not helpful for diagnosing absent seizures specifically. In young kids, you might think about specific metabolic or genetic screening.
What about spinal fluid?
A lumbar puncture for CSF analysis might be done if you're worried about an infection or inflammation in the brain, especially if the seizures are new.
And imaging, EEG.
For suspected epilepsy, brain MRI is the imaging test of choice. It's best for finding subtle structural causes. And the EEG, electroencephalogram, is critical. Catching the abnormal electrical activity during a seizure and ictal recording is the gold standard for diagnosis.
But a normal EEG doesn't rule it out.
Correct. A normal EEG between seizures doesn't mean someone doesn't have epilepsy. That's why prolonged monitoring, especially video EEG, where you correlate the brain waves with what the person is doing, is often incredibly helpful, particularly for sorting out seizures from non-epileptic events.
You mentioned psychogenic non-epileptic spells, PNES, a couple of times. Residents learn these can be a real diagnostic headache, right? Mimicking seizures closely.
Oh, absolutely. They can look remarkably like epileptic seizures, but don't have those characteristic EEG changes.
Mhm.
And to make it even trickier, maybe 10–20% of people with PNES also have epilepsy.
Wow, that complicates things.
It does. Diagnosing PNES often relies heavily on observing the skulls, ideally on video EEG. While they might look like tonic-clonic seizures, whole body shaking, unresponsiveness, there are often subtle clues.
Like what?
The movements might seem more chaotic or variable. Incontinence and injury are less common. The episodes often last longer. Things like pelvic thrusting or back arching are more common in PNES. Eyes are often tightly closed, whereas they tend to be open in epileptic seizures. And importantly, no cyanosis, no focal neuroscience, no abnormal reflexes afterwards.
And you mentioned a type that mimics syncope. How do residents tell that apart?
Yes, some PNES present without the dramatic shaking, looking more like a faint. Tilt table testing can sometimes help differentiate. In true vasovagal syncope, you see that characteristic drop in heart rate and blood pressure. In PNES, mimicking syncope, those vital sign changes are usually absent.
When should PNES be high on the differential?
We often think about it when someone with previously controlled seizures suddenly becomes refractory, or if the seizure description is just atypical. There's a known link with underlying psychiatric conditions and often a higher prevalence of past trauma or abuse. Suggestibility can sometimes trigger spells too, but the key is the EEG is normal during the PNES event. Long-term ambulatory EEG is often the way to confirm the diagnosis.
The source materials mention tables summarizing the key differences: syncope versus seizure, absence versus complex partial. Just as a quick review, what are a couple of the most useful differentiating points a resident keeps top of mind?
Sure. Syncope versus seizure. A clear trigger like standing or stress points to syncope. An aura points strongly to seizure. Skin color pallor in syncope. Cyanosis in generalized seizure. Tongue biting, major postictal confusion headache, much more likely seizure. Obviously, EEG findings.
And absence versus complex partial.
Absence. Very brief, abrupt onset offset, no postictal state. Complex partial. Often has an aura, lasts longer, more complex automatisms, usually has postictal confusion, and again, distinct EEG pattern.
This is incredibly helpful for understanding that initial sorting process for altered consciousness from a resident's viewpoint. Let's shift gears now to falls and drop attacks. They often overlap, but also bring their own set of considerations.
Yes, falls are a huge issue. Extremely common, especially as people get older, and a major cause of injury and healthcare costs. As a resident, you see the impact constantly. It's useful to distinguish drop attacks from falls in general.
How so?
A drop attack is usually defined as a sudden fall without any warning, maybe with or without a brief loss of consciousness. And crucially, they often can't be prevented by using a cane or walker. Falls, more broadly, just mean not staying upright when balance is challenged.
Okay, so for those sudden drop attacks, what kind of underlying causes would a resident consider?
The list is pretty broad. Could be cardiac, like a sudden arrhythmia. Could be epileptic, like an atonic seizure where you lose muscle tone completely. Could be vascular, like certain TIAs. Sleep disorders like cataplexy. Vestibular issues. Even structural brain problems like masses or congenital anomalies.
And for falls more generally?
Often related to more chronic neurological conditions affecting gait and balance. Things like peripheral neuropathy, stroke deficits, MS, Parkinson's disease, dementia, and just the general physiological changes of aging are a massive factor.
When a patient comes in with a history of falls or drop attacks, what are the absolute must-ask questions for a resident taking that history?
Oh, the history is paramount. You need the details. What exactly were they doing when they fell? Any warning, lightheadedness, vertigo, palpitations? Did they lose consciousness? For how long? History of prior falls. Seizures, heart problems, daytime sleepiness, falls triggered by emotion, headaches with weakness, vascular risk factors, any numbness, weakness, stiffness, vision or hearing problems, dizziness.
Seems exhausting.
It has to be. And while the neurological exam might show clues, especially for chronic conditions causing falls, it can be totally normal between drop attack episodes. That's often why neuroimaging becomes necessary to rule out structural causes. Further tests, vascular imaging, cardiac studies, EEG, sleep studies, maybe genetics depend entirely on the clinical picture. And you always have to keep psychogenic causes in mind too, especially with frequent near falls but no injuries.
Let's zone in on drop attacks with loss of consciousness. You mentioned syncope already.
Yes, syncope is a major player here. Severe arrhythmias or sudden drops in blood pressure cut off brain perfusion, leading to collapse. The classic Stokes-Adams attack, sudden, complete heart block, causes a fall with zero warning. That's something residents learn about.
Can other cardiac causes be less abrupt?
Sometimes. But older patients, maybe with sick sinus syndrome, might have amnesia for brief premonitory symptoms. Interestingly, cardiac syncope can sometimes present with vertigo-like symptoms, a sort of cardiogenic vertigo, and in rare cases, actual asystole, the heart stopping briefly, can cause vertigo and a specific eye movement called downbeat nystagmus.
And seizures can also cause drop attacks with LOC, right? Another diagnostic challenge for residents.
Absolutely. Epileptic drop attacks can happen from sudden muscle contractions throwing someone off balance, sudden loss of tone, tonic seizures, or even arrhythmias triggered by the seizure itself. Video EEG capturing a fall is incredibly helpful here.
Are there specific epilepsy types associated with this?
Yes, certain severe childhood epilepsies like Lennox-Gastaut or Dravet syndrome often feature drop attacks prominently. That's why, especially in kids or teens, residents learn it's important to consider tilt table testing to rule out syncope before jumping to an epilepsy diagnosis. For refractory epileptic drops, treatments like VNS or even surgery might be needed. And sometimes, paradoxically, certain anti-seizure meds can actually worsen drops in specific syndromes. Also crucial, if someone with a prior stroke starts falling, consider new-onset seizures, not just weakness.
Okay, now what about drop attacks without losing consciousness? What neurological causes come to mind for a resident?
TIAs, transient ischemic attacks, affecting specific brain areas are a key consideration. These can cause sudden falls without warning or LOC, maybe brief leg weakness that recovers fast. The exam between episodes is normal.
Which areas?
Most commonly implicated are the posterior circulation supplying the brainstem and cerebellum and the anterior cerebral arteries supplying the top front parts of the brain, especially areas controlling the legs.
Can you expand on vertebrobasilar insufficiency causing these?
Yeah, transient lack of blood flow in that system can affect pathways controlling movement or balance, causing a drop. Usually it's not isolated. Patients often have other temporary symptoms like vertigo, double vision, ataxia, weakness. But sometimes a drop attack can be the first warning of something serious, like a basilar artery clot forming. Causes can be emboli, vessel narrowing, or subclavian stele.
And the anterior cerebral artery, ACA, how does that cause drops without LOC?
ACA ischemia can hit the motor cortex controlling the legs. If someone has a common anatomical variant where both ACAs come off one trunk, a single small clot could potentially weaken both legs suddenly, causing a fall without affecting consciousness. Rarely you see this with carotid dissection or certain vascular malformations. There are also things called limb-shaking TIAs that can cause falls.
It's fascinating that structural brain issues, not just vascular ones, can cause sudden drops too.
Right. Things like colloid cysts in the third ventricle. Their second most common symptom after positional headaches can actually be unprovoked falls, even with a normal exam. Pineal cysts rarely can cause sudden pressure spikes. Chiari malformations are linked to Chiari drop attacks, sometimes resolving after surgery. Less commonly, other posterior fossa masses or even things like cysticercosis in the past could present this way, though usually with more chronic symptoms too.
You mentioned otolith crisis earlier. That sounds very specific.
It is, also called Tumarkin crisis, seen in Meniere's disease. It's a type of vestibular drop attack. Sudden fall, no vertigo. The idea is the inner ear balance organs misfire, triggering inappropriate postural reflexes. Feels like being thrown down. Can happen in older folks with unilateral vestibular loss too.
And cataplexy, associated with narcolepsy, right? How does that fit in?
Cataplexy is a sudden loss of muscle tone, usually in the legs, while conscious. Can range from knees buckling to a full collapse. Typically brief, often triggered by strong emotion like laughing or surprise. You can see EMG silence in the muscles. While classic in narcolepsy, it can rarely occur symptomatically with other conditions or even in isolation.
Okay, so we've covered drop attacks specifically. Broadening back out to falls in general, what are some major underlying conditions that increase fall risk beyond those causing sudden drops? Things residents see day to day.
Falls are so often multifactorial. Neuromuscular disorders are big contributors. Neuropathies causing weakness and sensory loss, myopathies. Diabetes is a double whammy with potential neuropathy and eye vestibular issues.
Yes.
Spinal cord problems, nerve root issues, channelopathies, neuromuscular junction disorders, all can impair stability. Falling can even be the first sign of an acute polyneuropathy.
And MS stroke.
Definitely. MS patients often have gait and balance problems leading to high fall rates, stroke deficits, weakness, ataxia, sensory loss. Visual problems all dramatically increase risk.
What about conditions that don't necessarily cause weakness, but affect coordination or processing?
Severe metabolic encephalopathies can cause asterixis, that flapping tremor, which can sometimes mimic drops. Cerebellar disease is a huge cause of falls due to poor coordination and truncal instability. Degenerative ataxias are notorious for falls. Even episodic conditions like episodic ataxia or hemiplegic migraine can feature falls. Normal pressure hydrocephalus causes gait issues.
You also brought up cryptogenic falls in the middle-aged. How do residents approach those unexplained falls, often in women?
Yeah, those can be puzzling. Sudden forward falls, often bruising the knees, no clear warning or LOC reported, legs just give way. Gait seems normal between episodes. The cause isn't fully clear, but there seem to be associations with underlying balance issues, maybe vestibular dysfunction, fibromyalgia, migraine, poor sleep, foot problems, obesity. Sarcopenia likely plays a role too. It requires careful evaluation to rule out other causes.
And it seems like just aging itself is a massive independent risk factor.
Huge. Even healthy aging involves changes that increase fall risk. Gait changes, slower speed, which itself predicts mortality. We know specific brain regions and networks are crucial for gait and balance, and age-related changes like white matter disease or neurodegeneration disrupt these. That link between cognitive decline and fall risk is very real. Even subtle things like someone needing to stop walking when they talk, that's a red flag residents learn to spot in older adults.
And the psychological aspect, fear of falling.
Yes, very common after a fall, but can also develop even without falling, especially in people with diabetes, obesity, depression, more common in women. It leads to activity restriction, deconditioning, making falls more likely. It's a vicious cycle. There are scales to assess it, and interventions like exercise and CBT can help.
Lastly, basal ganglia disorders like Parkinson's. Residents see a lot of falls in these patients.
Extremely high risk in Parkinson's. Risk factors include disease duration, depression, cognitive issues, motor fluctuations, REM sleep behavior disorder, RBD, autonomic problems. Sudden drops can happen related to dopamine levels. Freezing of gait is a major fall risk, linked perhaps to cholinergic pathways and maybe even RBD. Treatments like DBS don't always reduce fall risk. Other Parkinsonian syndromes like PSP often cause early, backward falls. RBD itself causes falls during sleep and is a precursor for these diseases.
So for the general aged population, it's a combination of everything.
Pretty much. Declines in sensation, muscle strength, vision, vestibular function, cognition, postural reflexes all contribute. Orthostatic hypotension is key. Significant BP drops on standing, or even with head turning, predict falls. How well BP recovers after standing predicts mortality in elderly fallers. Management has to be multifaceted. Assistive devices, treating orthostasis arrhythmias, home safety, reviewing meds, exercise balance training, addressing fear of falling, vitamin D, vision care, the list goes on.
Even walkers aren't foolproof.
Surprisingly high fall risk associated with walkers may be due to how they're used or the underlying frailty of users. Exercise helps, but maybe less so in dementia. There's work on tech for fall detection and protection. But fundamentally, managing falls in older adults, as a resident learns, needs a really comprehensive, individualized approach.
It's honestly almost overwhelming just listing all the factors that can contribute to falls. It really highlights the complexity neurology residents are dealing with when evaluating these patients.
It absolutely does. It underscores why you need such a meticulous, systematic approach, digging into the history, doing a thorough exam, using investigations smartly to pinpoint the specific contributors for that patient.
Well, this has been an incredibly thorough deep dive into episodic impairment of consciousness and falls, especially seeing it through the lens of a neurology resident navigating these diagnoses. We've covered so much ground.
Yeah, from syncope versus seizure distinctions to all the varied causes of falls and drops.
Right. It really strikes me how similar presentations can come from such different places physiologically. I think for me, one aha moment was seeing the connections, like between sleep disorders and movement disorders contributing to falls, things you might not initially link.
And what's always fascinating, especially when you're learning as a resident, is how crucial pattern recognition becomes. Combined with really understanding the physiology, you start to see how one small detail in the history or one subtle exam finding can be the key that unlocks the whole thing.
So looking forward, these conditions are so common, especially with aging. From the perspective of a neurology resident entering the field now, what seem like the most promising areas for future research or prevention strategies?
That's a great question. It makes you think about how technology, better diagnostics, and new therapies can change things. For example, wearable tech for continuous monitoring. Could that help predict or diagnose these events better?
Possibly.
More research into the brain changes affecting gait and balance, developing really targeted rehab that holds promise. And from a resident's viewpoint, getting involved in research exploring these things or advocating for better integrated fall prevention programs in healthcare that feels like where residents can really make a difference moving forward.
That's a really powerful thought, how today's residents are shaping tomorrow's care for these common and challenging conditions. For you, the listener, we hope this deep dive offered a clearer picture of the complexities here, maybe a new appreciation for how intricate the nervous system is and the challenges involved in figuring things out when it goes awry. Thanks for joining us.